I want to welcome those of you who are already signed on. I'm Susan Hickman. I'm the director of the IU Center for Aging Research and a professor in the IU School of Nursing. I'm really delighted to be introducing our dynamic duo today, and I will start by introducing them individually with Shelley Johns. Dr. Johns is an associate professor of medicine in the IU School of Medicine and a Regenstrief investigator in the Center for Health Services Research. She's a clinical health psychologist with an adjunct appointment in the Department of Psychology at the IUPUI Purdue School of Psychology. Dr. John's patient-oriented research primarily focuses on testing integrative mind-body interventions to reduce cancer-related fatigue and associated symptoms for post-treatment cancer survivors. All of her research prior to 2019 had focused on developing and testing mindfulness and acceptance-based behavioral interventions to build psychological flexibility in adults with cancer and their family caregivers. When I asked her about comments to introduce her, she noted she's shown psychological flexibility herself in accepting Nicole Fowler's invitation to translate an intervention she's tested in cancer to meet the needs of dementia caregivers, which was a new population for her. Dr. Nicole Fowler is an associate professor of medicine at Indiana University School of Medicine and associate director of the IU Center for Aging Research at Regenstrief. She's also a scientist in the Indiana Alzheimer's Disease Research Center and the Center for Health Innovation and Implementation Science at IU. Dr. Fowler is an applied health services researcher in the areas of non-pharmacological approaches in dementia care, family caregiving, and medical decision-making for older adults with cognitive impairment. The overarching focus of her research program is the development, testing, and comparison of evidence-based and patient-centered interventions that improve the quality of care for older adults with Alzheimer's disease and their family caregivers, in particular medical decision-making interventions to support family caregivers. Her research has been funded by multiple foundations, along with the National Institutes of Health and the Department of Defense. She shared that she's learned a lot about herself over the past 15 months of the pandemic, and one is how much she likes getting dressed up for work. So she said she's looking forward to wearing her spring 2020 wardrobe a year late when we return to the office in 2021. Shelley also noted that Nicole has shown considerable psychological flexibility in embracing an innovative approach that goes well beyond traditional cognitive behavioral therapy. I'm going to now turn the floor over to Dr. Shelley Johns, who will kick off the presentation.
Thank you so much, Susan. And I'm going to try to share my slides now. So can anybody tell me if the slides are up? Looks like they are. Okay.
They are.
All right. So I'm going to start us off today, and then I'm going to hand the mic over to Nicole here in just a few minutes, and we're just going to kind of bounce back and forth a little bit today. So here are the objectives for today's talk. We'll talk about common challenges for caregivers of persons with dementia. We'll also, kind of give you a quick rundown on the state of the science on existing interventions and why Nicole thought something different was needed and how we got started together. And then we'll tell you a little bit more about acceptance and commitment therapy. We won't go into, tons of detail about that because I've presented on ACT a couple of times, but just a nice reminder never hurts. And then we'll also tell you about some of the results of our Regenstrief funded cross-center pilot. It was a mixed methods pilot, and we'll tell you about some of the exciting outcomes that we had. So how all of this got started was back in June of 2017. So gosh, that was a long time ago. I had presented on a pilot study that I had conducted that was funded by an IU Health Values grant and also the Walther Cancer Foundation. Thanks to Craig Brader, who is the head of the board, at Regenstrief. He was, the head of the supportive oncology wing of Walther Cancer Foundation at the time. And they funded a 3-arm pilot where we enrolled 91 breast cancer survivors in just 12 weeks of active recruitment. So I'm used to rapid recruitment. Anyway, we had a really successful pilot, and I'll show you we've published the paper on that recently, and I had submitted 3 R01 applications based on that pilot. And that was the pilot that Nicole heard me present on, what was that, 4 years ago. And she came up to me after that WIP where I presented those results. And she said, listen, I think that what you're offering to your breast cancer survivors with clinically significant fear of recurrence could potentially be useful for dementia caregivers, because they're all dealing with unwanted stuff in their life that really isn't going away and isn't going to change. And, she caught my attention with that. I had never thought about working with any other population outside of cancer. But the more Nicole explained to me about the plight of dementia caregivers, the more I thought, she may be onto something here. So anyway, back to my story with my cancer work. I had submitted, this grant 3 times to the National Cancer Institute, and you can see my scores there. I mean, almost got funded the first time with that 10th percentile score, but the funding pay line at the time for the NCI was the 8th percentile. So that was heartbreaking. And then we kept trying and trying. Well, finally, if you haven't heard yet, thanks to all of your help, everyone in this audience who has helped me time and again at these WIP meetings, finally, we got a decent score this time. And so I just found out, I think it was in March, that we found out the 4th percentile score. So I'm waiting on the notice of award. The council meeting is supposed to be sometime, this month, but this month is winding down. So anyway, I just wanted to again thank all of you for the feedback that you've given and the support and help that you've provided to whip this application into shape. So let me tell you a little bit about acceptance and commitment therapy, or ACT. And I think that you're going to see why Nicole thought this could be helpful, and then she can jump into and explain. But ACT is a mindfulness and acceptance-based behavioral therapy. And the thing about ACT is it just acknowledges what you and I already know, all of us know, is that, pain in life is inevitable. Psychological pain, physical pain, we're going to have it. As long as we're living a rich life, we're going to have some pain. We're going to have some disappointment. We're going to have some heartbreak. We're all going to suffer grief and loss, when people in our life die. We're all going to suffer, stress with a pandemic and all of that. So instead of trying to, make the pain go away, or trying to, CBT people out of, their thoughts about their pain, ACT just really helps people to increase their psychological flexibility, their ability to be willing to have pain, in order to live a rich and meaningful life, to not get hooked into the content of our thoughts, to be very mindful, of the precious moments in our life, and, to just not get too flapped, when things don't go our way, or when life throws us curveballs. So the thing about, cognitive behavioral therapy is a proven evidence-based treatment, and it has its place. It absolutely does. I was trained at the Beck Institute where, cognitive therapy was developed. So I get it. I understand the value of cognitive therapy and cognitive behavioral therapy. But when people are dealing with unwanted circumstances that are not going to go away, sometimes I was finding clinically that it was just falling a little flat in clinic when I was trying to, help people to think differently about their circumstances. And so, so I don't know, Nicole, I didn't know if you wanted to, to jump in, kind of at this point, kind of to talk about what appealed to you and why you wanted to collaborate.
Sure. Yeah, I think, yes, and I saw Peter's comment. Shelley has had amazing persistence with her work, and it's really exciting that her R01 is getting funded. So I'm really proud of her. In addition to hearing Shelley's, where she was talking about her work with cancer survivors and ACT, it was around the same time, I don't remember if it was before or after, but Chris Callahan had presented a WIP on his final results of his last kind of, big trial that was called ADMIT. And for those of you who, may not know, sort of one of the things that the IU Center for Aging Research has been sort of known for over the past sort of 20 years is the development of what you might call kind of macro interventions, sort of system level interventions, but really, around the space of collaborative care. So kind of specialty care who understand the disease, whether it be late life depression or dementia, and working with primary care. And so there has already been an evidence base that had been established around dementia collaborative care and its positive impact on, decreasing behavioral and psychological symptoms in persons with dementia. It decreased caregiver distress, caregiver depression. And then when Chris did this sort of additional trial where he actually said, okay, we have collaborative care, we've shown that this works. Let's see if we can now make some, other improvements. And so they designed ADMIT to target functional decline with the sort of hypothesis that, well, maybe if we add on to collaborative care, which did have a little bit of sort of CBT components to it, but predominantly it was more of a systems intervention, kind of working with the patient and the caregiver, working with the primary care provider. They said, what if we add some occupational therapy intervention in the home to see if we can slow down the functional decline, and then also ultimately continue to impact caregiver distress and burden in a positive way, thinking that they could slow the functional decline down, it would be helpful for the caregiver as well. Well, it was essentially a negative trial. And so it had me sort of thinking, and they must have presented, Shelley and Chris, at around the same time, because here was Chris kind of presenting on an additional feature of, supporting dyads where they were targeting functional decline. Here was Shelley kind of talking about designing interventions about being in a space that's sort of unchangeable and kind of crappy. And I drew on my earlier work, kind of studying things like anticipatory grief and its relationship to caregiver problem solving. And I thought maybe maybe the target's different. So maybe sort of thinking about, a macro intervention where we're trying to kind of impact decline or function. Maybe it's kind of targeting specifically around something that's more existential. And I use that word, and I'm not a psychologist, that's Shelley's role. But when I would try to explain to her, I said, even with sort of this idea where all of these needs are met, and we know there's lots of caregivers who unfortunately don't get all of the needs that, met that they have, but even spaces where, access isn't an issue, or finances aren't an issue, or resources aren't an issue, there's still a level of suffering that people have just because of living in a space of watching the person who they love change in a way that's not always a positive change. Their relationship to them is changing. Some people say the elements that make the person that they love, sort of them, are declining. And so maybe that's what we sort of need to target, this idea of this unchangeable situation of being a caregiver with some of the things that make that so hard. And so that's the idea of sort of bringing the two ideas together. So when I talked with Shelley about it, I think one of the first things we did was we both kind of said, okay, and we sort of did a literature search, and we actually found out that in 2017, 2018, there was only one group in Spain who had ever even thought about using this type of intervention for dementia caregivers. There wasn't anything in the US that had been thinking about how to design an intervention around these types of caregiver expressions and then outcomes. So that was sort of the marriage, the associative thinking, I guess, of sort of different types of projects. And so it leads us to tactics. And I think maybe Shelley, your next slide kind of highlights potentially some of the things why we thought ACT might be so helpful for caregivers, dementia caregivers.
Absolutely. And again, I just want to acknowledge again and again Nicole's wisdom and her insight in reaching out to me, because I was so caught up in the drama of my own R1 applications to the NCI. I really wasn't thinking very broadly. I mean, I think about collaborating with my oncology colleagues, but I really wasn't thinking about diving into a new population. So I really appreciate these meetings that we have, whether we call it whip or grand rounds or vanilla ice cream. It's these meetings are really important because they ignite ideas and collaborations. So I just think that's really important. So you can see on your list here, there's a laundry list of different challenges that are very common. And this was a study that was done by the Center to Advance Palliative Care and also the Mary West Health Institute. And they did focus groups and qualitative interviews and different ways of connecting with dementia caregivers. And the percentages that you see here are the percentage of dementia caregivers who rated each of these things as their #1 challenge. And so you can see some of those top few really get at some of that just existential, angst, and just some of the psychological suffering that some of these caregivers experience. And then the other reason why we thought an acceptance-based approach would be helpful is because in that same study, look at some of these challenging behaviors. Dementia is progressive, as you all know, and some of these behaviors in the loved one with dementia, they're not going away. And so there needs to be some radical acceptance of some of these behaviors, and also some wise action, learning some skills to better manage these. But the acceptance-based approach just made so much sense. And then if you're going to get a little whiplash here because I'm going to go backwards. But the reason why I'm showing this picture is because this really represents, I think, what ACT is about. Because if you consider that this swimmer here, this very, shapely young swimmer with a great core, just imagine that she is a dementia caregiver and that beach ball is her emotional pain about her, let's say she's caring for her mother, her mother's cognitive decline, the fact that her mother no longer reliably knows who she is, can't remember her daughter's name, the fact that, this daughter has loved and respected her mother, and she sees, her mother's personhood, radically changing and diminishing. And imagine that this dementia caregiver is spending all of her energy, all of her time, effort, energy, all of her resources trying to not think about those things and trying to control her emotional, her understandable grief and her understandable sense of loss. She's spending a lot of time trying to control stuff that isn't really very controllable. And imagine if this progresses where she really wants to numb herself out and then she starts, drinking or worse. So the reason why we wanted to implement an ACT intervention is because it gives caregivers healthy, adaptive alternatives so that they can relate more effectively with their thoughts and feelings, with their concerns about their future, with their own fatigue, with their own stress, so that they don't have to resort to maladaptive coping behaviors that is just going to make their life much worse in the long run. So here, what Nicole and I have shown for you is just our timeline of our collaboration so that you can see kind of what we've been working on. And you'll notice that, the RFA for the Regenstrief Cross Center pilots, it was released in January of 2019. We applied and we were selected for funding. There were several other teams that were also selected. Then shortly after the funding announcement was made, we got the study IRB approved, and then we enrolled our first caregiver that summer. And that was just 2 years after Nicole Fowler came up to me and said, listen, we need to collaborate. And then from there, we finished all data collection the following summer. And I also want to see that arrow right there. I'm going to circle back to that at the end of the presentation to tell you some other things that we did kind of in there that there wasn't room for here. And we also have the paper already published. And so we'll show you that paper. Nicole is the lead author of that paper. And then I am working on a paper right now reporting on the qualitative or the mixed methods outcomes. And then I'll be the lead author of that paper. And we kind of work that out at the beginning of the study, which is another great thing to keep in mind. When you're collaborating, we really need to work out those authorship details early on just to make sure everybody's on the same page. So these are just a few kind of facts about dementia that you've probably heard or seen before. As you know, dementia is a very common progressive neurological condition that affects, I think it's about 6 million Americans right now, and then there's about 16 million Americans providing unpaid care to a loved one with Alzheimer's disease or a related dementia. From henceforth, I'm just going to say dementia, but you know that it includes both. And you can see the number of hours that this entails, the amount of energy, the amount of time, and then what this care is valued at. You can see in the middle of the slide all of the negative consequences for these dementia caregivers and why we have such tenderness and such a passion for trying to serve their needs given all that's on their plate. And then the other thing that was really impressive to Nicole and I, when we really dove into that lit search like she was talking about, is that even when you look at dementia caregivers who had no diagnosis of anxiety or depression when they first began their dementia caregiving journey, 60% of them in one study developed a depressive or an anxiety disorder, a DSM-5 diagnosable, psychiatric condition within 2 years of delivering care. And it's understandable why, based on, those tables that we showed you earlier about some of the things that these caregivers deal with. And so just, because, dementia is characterized by chronic and progressive cognitive decline and functional dependence, caregivers have to take on a lot of responsibilities. Oftentimes, these are older adults who are caring for a partner or a spouse, and they're having to compensate, for all of their loved ones, losses and lack of autonomy. And in fact, one of our caregivers that, that we have some qualitative data from later, she was talking about how she had never had to pay a bill before. She had never had to make a decision about, hiring workers to come in and, fix the electricity or whatever. And she was very lost with all of this. She was an older woman, and it was very confusing and very upsetting for her. And this is just kind of a laundry list of some of the top interventions that have shown, the most efficacy in terms of dementia caregiver interventions. You'll notice, CBT is right up there with one of them, as one of them. And so I wanted to just kind of review quickly for you just some of the meta-analytic results that gives you a little bit more of an idea of why Nicole and I wanted to go this direction. So oftentimes, anxiety isn't the primary outcome of these studies, and that was what I was most interested in, was the anxiety. And since there was a dearth of studies that had tested, dementia caregiver interventions with anxiety as the primary outcome, we definitely wanted to go that way. But look down in that Hopkinson meta-analysis, you can see the effect sizes for, depression and stress are pretty low, not very impressive, still significant, but, pretty small effects. And then the outcomes on anxiety were not significant and were in the wrong direction. So, and one of the reasons why that could be, in my mind, is that some of these interventions heighten caregivers' awareness of things that they need to be, kind of concerned about, without necessarily giving them the tools that they need to deal with the anxiety. So that's why I think in some of these clinical trials that where they did assess anxiety, why it kind of goes the wrong direction a lot of times. And just to, spoiler alert here, that is not what happened in our Regenstrief funded pilot. So stay tuned if you can. The other thing is that the quality grade of most of the research in this meta-analysis was really low, and there were just lots of methodologic limitations, with high risk of bias. So anyway, there's lots of room for improvement there. So the other thing that Nicole and I noticed is, issues related to scalability. So of the 10 CBT studies that included anxiety among the outcomes, none of them were conducted by phone. And we think that's essential, when we're doing a study in Indiana, or really anywhere for that matter, because many of our patients with dementia and their caregivers live in rural areas, not in Indianapolis. And so they're not going to be able to get in, to an in-person face-to-face intervention. Several of them were conducted as in-person groups. Well, we know how that works during COVID, right? I mean, that's going to not be happening. Certainly we can do these, Zoom meetings and things like that. But the other thing, and this was where Nicole and I almost came to blows, and I'm so glad that she talked me into this. Nicole said, we can't be having a bunch of psychologists delivering this intervention. Y'all are too expensive. And I, was being a little bit of a snob, and I'm like, listen, there's not just anybody can deliver this ACT intervention. I've been working on this for 15 years. I'm still, learning new things about this intervention every day. And Nicole said, in a nice, way, she said, get over yourself. And this is what we're going to do. And this is how we're going to get, innovation for our study. Is I think we need to train bachelor's level interventionists, to do this. And I just, I thought she was nuts. I didn't think there was any way that was going to work. But boy, did she prove me wrong. And we'll tell you more about that here in just a second.
Well, I want to add to that just quickly too, is I think those of you who sort of know me and know the sort of the types of, work that I like to do, and also, carried over from the tradition of what, IU CAR has done, is thinking about the scalability and the ability to implement it if it works. And so not having it necessarily be tested in an environment that then becomes it impossible to implement it later. And in addition to what Shelley mentioned about anxiety not being a common target, for a lot of caregiver interventions, one of the biggest complaints of the interventions that do work on other outcomes is the fact that we don't have them set up in a way to make them scalable and implement them. So many people don't get the benefit of things that we do know work for things maybe like depression or knowledge or skill building types of intervention. So it was really important to me that if we were going to test this, it was going to be in a way that we could easily think about how to kind of make it scalable and put it into other settings if it worked. So yeah, it wasn't because I thought Shelley was too expensive or snobby. It was
well, there might have been a little of that, but I'm so glad that, when we can really put our heads together on some of these things, it can really make a real difference. So I just wanted to show you our lovable and incredible team. So you probably know all the people here, but Dr. Nicole Fowler on the left, co-principal investigator. Then next is Patrick Stutz. He is a research coordinator who sits at Regenstrief, but he's in the IU School of Medicine. He's on my team. And then Christina Bacco is next, and she was the lead recruiter, and she did all of the study assessments for this study. So Christina was an amazing resource for this study. And then next we have Shelley Suarez, who was a project manager at Regenstrief, and she is not with us right now, but she's still with us in spirit. And then next is Taylor Gowan, and I'm going to tell you a little bit more about Taylor here in just a moment. But Taylor was our bachelor's prepared interventionist, and you'll see the kind of results that she produced for this study here in just a moment. And she did it single-handedly because she was the only interventionist in this first pilot. And then I'm on the end. So just to review some of our methods, this was a mixed methods study. We did some qualitative interviews at the post-intervention survey time point. It was single arm because, again, we didn't know if this was going to be feasible and acceptable to our dementia caregivers. And plus the pilot mechanism had, quite limited funds. And so we started with a non-randomized pilot, and then we have since conducted and completed a randomized pilot. And then we're conducting a second randomized pilot right now. We'll talk about that in a moment. Also repeated measures. We assessed at baseline, we assessed at post-intervention, which was about at the 6-week mark. And then we assessed follow-up at 3 months post-intervention and 6 months post-intervention. The primary objective was to assess feasibility, acceptability, and then preliminary effects of tactics, for 16 dementia caregivers. And then the primary outcome was anxiety. And then we also assessed several other outcomes that we're not going to be reporting on today. But I understand that we're presenting a WIP at the VA next month. So if you're really interested in all the details, you can join us then. You can see the inclusion and exclusion criteria here. The only one that I'll really highlight is everyone who enrolled had to have clinically significant anxiety as assessed with Kirk-Cronke's GAD-7 scale. And this was a decision point where we wanted to make sure that we could show an effect. And so, the higher the anxiety at baseline, the more effect you're probably going to show. The downside, though, is we had to turn a lot of people away who were really interested, who didn't quite meet that clinically significant cut point. So we'll also kind of talk about that soon. And then you can see all of our clinical partners. It was the Indiana Alzheimer's Disease Research Center, Eskenazi Health, and also the IU Health geriatric psychiatry practices, and I also think the neurology practices. So anyway, here's kind of the timeline of the study. As I mentioned, we had 4 time points represented by T1 through T4 in that top row. That T2, Christina Bacco did the quantitative survey, on the phone with participants. And then a short time later, then someone else conducted qualitative interviews. And, qualitative interviews are, only as good as as the interviewer. And I tell you what, we took a chance. We let one of our life health sciences interns do most of the qualitative interviews. Patrick Stutz, my research coordinator, also did a few. And she is getting ready to go to med school, hopefully here at IU School of Medicine. And she did just a fantastic job with these interviews. You don't usually get that level of skill, that level of probing with somebody who is inexperienced, but she was a fast learner, and she's going to make a great physician for us sometime soon. So, and we're currently, working on the analysis, with a mixed methods results now, which is all the way down there, the right there. So just to tell you a little bit about the qualitative interviews, we asked 5 broad open-ended questions. You can see those kind of in the middle of the slide there by the figure. The interviews, as always, were audio recorded, transcribed verbatim, and checked for accuracy by a separate member of the team, just, because we wanted to make sure that we got it right. And then we're currently doing, we've actually finished the thematic analysis. And so I am trying to get all of the themes kind of situated and ready for the team to do their final review. So back to ACT. So the tactics intervention that we delivered was 6 weekly sessions. And people pretty much stuck with the weekly schedule. When you look at how many days they had between the first session and the 6th, it was, the average came to be, about, half a week, longer than that. So every now and then, people had to take a week off, due to caregiving demands or vacation or work stress or whatever. But we pretty much stuck with the weekly plan. These are the 6 core processes of ACT. We'll start at the tip top, which is basically mindfulness, really making contact with the present moment, recognizing what's here, what are the thoughts, what are the feelings, what are the bodily sensations that I'm having in this moment, which can inform, choices, that we make for self-care. Right below that contact with the present moment, there in the center, is what's called self as context. That's a fancy $50 term for perspective taking, and just recognizing, our own self stories sometimes and how we get hooked into those. Over on the left, we've got acceptance, which is, being willing to have anxiety if it means that you get to do things that are really important to you. Like caring for a loved one with dementia might be very, very important to you to do, and there's going to be some anxiety that might come with that. Cognitive diffusion means just recognizing thoughts as thoughts without taking them literally or letting our thoughts drive our car or dictate our behaviors. Then up on the upper right, our values. This ACT intervention is really about supporting caregivers and any of us in clarifying our values, what we want our life to be about, what we want to be known for, and using those values as a guide to action, and then committing to actions consistent with our values. What we have found in cancer research, as well as in this work with dementia caregivers, is that when people continue to act in service of their core values, even when they're in the middle of a tsunami, a pandemic, or a concentration camp in God knows where, people can still have a meaningful and rich experience, even when they are surrounded by a nightmare. And so we're definitely not going to go into this, and I know the text is too small, but this shows you that each of our sessions had a core theme that was linked to one of those 6 core processes. Every session had at least one mindfulness practice that Taylor Gowan led and guided the caregiver on. And then there were always home practice invitations that were given to the caregivers for ways that they could continue to implement the skills from the session in their life to their advantage. And those, we invited people to practice mindfulness daily using lovely recordings that Taylor made with her own voice. And then we also encouraged values-based action that each caregiver decided for themselves what they were going to focus on each week. And so here's the paper that, again, Nicole is the lead author of this paper. It was just published, I don't know, I think it was in March, right, Nicole? So this one is out there and available for viewing. So in our pilot, you can see we've got the demographics here for you. Most of our caregivers were partners or spouses. Most of them were largely female. We had a few gentlemen in there, but mostly female. They were older. The average age was, about 69 years old. About half of them were college graduates. Most of them had a comfortable income. And, the other thing that is one of our challenges with this study is that it was completely, Caucasian. And so in our current pilot that we're conducting right now, we're really taking a much stronger approach, making sure that we're going to enroll a more diverse sample. And this was a pretty healthy group of caregivers as well. As you can see, most of them had good, or all of them had good to excellent health. And then here you can.
So could you go back to that slide for a second? I think the other thing that is important to highlight is if you look down almost towards the bottom where it says dementia severity. So that is a rating of how severe the person they're caring for's dementia is. And so if you take a look, I mean, the majority would be around the moderate stage. These were all people who were still living in a community. There wasn't anybody in assisted living or nursing homes. And then 1 was severe, 4 with mild. So that was another interesting piece. We had hoped to get maybe a little bit more variation. But I think just to kind of show the folks, those of you who know, so these are people who had at the moderate stage of dementia.
Right, yeah, absolutely, good point. And so here you can see the kind of the flow diagram here. And so over 25 weeks, Christina Bacco approached 48 caregivers, and about 15% of them refused eligibility screening. And so of the 41 who screened for eligibility, 39% of them were eligible. The biggest reason for lack of eligibility was that, not having, clinically significant anxiety. And so we have kind of modified that a bit for our current pilot, where we're allowing a little bit of a lower score, still up there, but not at the level of 10. And so I just wanted to kind of show you here some of because again, the main point of this study was to assess, feasibility, acceptability, and preliminary effects. And these are your feasibility outcomes here. So again, 39% of our caregivers screened eligible. All of the eligible caregivers enrolled, which I thought, really showed, kind of a hunger for these types of interventions. Also, we had really high attendance. So of the people who attended the first ACT session, 100% of them stuck with it and attended all the sessions. But we did have, if you remember back here, you can see that there was one person who withdrew at the kind of the top right there, withdrew even before their baseline. So they basically consented with Christina, and then they were lost to follow-up. We never could reach them again. So they didn't complete their T1, and they certainly didn't do any of the sessions. And then we had retention, even when you take into account that one person who consented but then was lost to follow-up, and then one other person who withdrew when her loved one died. I think it was between the T2 and the T3 assessment. We had, 87.5% retention through the T4 assessment. So really strong markers of feasibility and acceptability that exceeded our expectations. And then here you can see, I know the print is really small, but I'll just kind of highlight a few key points for you here. This is the acceptability ratings. And so what you can see here is that a large number of people rated their satisfaction as very high. So on a 1 to 10 point scale, the mean was more than a 9 in terms of how satisfied they were with their tactics experience. And then there was high levels of satisfaction, those questions in the, below the main line there, that's on a 1 to 5 scale, and all of the outcomes are, nearly 4.5 and greater in terms of being satisfied with the number of sessions, which was 6, the length of sessions, which was an hour, the topics of the sessions, the skill of Taylor Gowan, and also satisfied, with the study materials. We gave everybody a study notebook that had, lots of, worksheets and different parts to explain, the study session material. And then we also gave them, the mindfulness recording that Taylor produced. And so here you can see, this is kind of what you dream for, right? So our primary outcome was anxiety, and you can see the group mean at each of the time points. So at baseline, our caregivers were well above that clinically significant cut point, which is indicated by that solid black line. Then at the post-intervention assessment, you can see, compared to baseline, there was a large effect size, a large and significant effect size. And there was that nice stair step down in terms of those anxiety scores. So at each time point, and we think it's because caregivers were continuing to use their skills that they learned, the effect size remained large and significant and kept decreasing over the course of time. So we were really, really excited about this. And, the other thing that I'll mention is in ACT studies, oftentimes what happens is there's not a ton of decrease post-intervention because it really takes a while to start embracing these skills and implementing them in your life to your advantage. And so oftentimes what you see is there's, kind of not a lot of decrease until the follow-up. And that's usually where ACT really makes a difference in comparison with other active interventions, is that, other active interventions might do really well at the post-intervention, but then people forget the skills. But with these ACT skills, these are life skills that people remember because it's about their values, their core values. It's about being present, for the precious moment of our lives. And people really seem to embrace those, as evidenced, by what you can see here. So again, I just wanted to once again state, it's obvious to all of you based on the data how successful this small, single arm pilot was. But we had such wonderful recruitment feasibility due to the strengths and the skills and the amazing presence of Christina Bacco. And then Taylor Gowan, again, learned how to deliver ACT, and she has worked her tail off trying to become, a skillful ACT therapist. And she has continued to improve, so much so that her ACT skill scores on our fidelity monitoring rival mine. I'm an interventionist in Dr. Catherine Mosier's R01, in cancer, and Taylor's ACT skill scores rival mine. And I've been doing this for 15 years. Taylor's been doing it for a minute. So I just want to emphasize, we've got some fantastic staff members at Regenstrief that we are grateful and lucky to have. So I just wanted to mention that. So anyway, we don't have a lot of time left, and there's way too much here on this slide, but I wanted to show you kind of what we've come up with so far in terms of the qualitative themes. And so you can see here that the three main overarching themes that revealed themselves in the qualitative interviews is that our caregivers really reported reduced emotional reactivity, which is exactly what we would expect in an ACT intervention. As people start learning how to accept their unwanted internal experiences, like their anxiety or like their fear or like their sadness. They, as they become more skillful with acceptance and mindfulness, they're just a little less emotionally reactive, where they're just a little more unflappable by, the things that happen, able to think a little more objectively. And that's that self as context piece that we talked about before, the perspective taking. And then you can also see that the next gray bar down is greater compassion for self and others, even though that's not directly listed as one of the 6 ACT core processes. That's what mindfulness is all about. It's about, trying to cultivate compassion, not only for ourselves, but also for other people, including the person with dementia. And so, as you can see, some of the sub themes there, patients were, or caregivers were, really able to recognize the reality of their care recipients' abilities and their limitations with less, kind of with greater compassion. They were also, discovering the importance of self-care and ways to strategically weave self-care in, even when they were, busier than 2-fingered transcriptionists, right? Because many of our caregivers were still working, some of them were still working. Some of them were providing, round the clock care to their loved one. Some of them were also taking care of grandchildren and, all sorts of things, but still finding pockets, feasible pockets of self-care, embodying some self-kindness and practicing values, not just their caregiving values, but having a broader, more psychologically flexible approach to their values. And then finally, psychological flexibility, which is what ACT is all about. And so you can see just, kind of looking at some of those quotes there, like that first one, living, up to my values is extremely important for me, to stay focused, on my life and to live the kind of life that I really want to have, and really supporting these caregivers and being able to do that. So I would love to read all of these quotes to you, because they are just, they're really inspiring and really just, really make all of the hard work that we put in worthwhile. The caregivers also, in the qualitative interviews, we asked them for suggestions for improvement. And the numbers beside each of these were the number of caregivers who reported that particular issue. So again, I think we had qualitative interviews with 14 of our caregivers, or was it 15? I'm trying to remember now. But 4 of them kind of talked about, maybe having shorter session length. At that time, we were going a little bit long. That was one of the things that, that Taylor really wanted to work on in the second pilot, is really getting her timing down to where we could deliver these sessions in 50 to 60 minutes. And so she has been very successful in doing that. Some of the people also had mentioned, 4 of them said that they really didn't understand or even appreciate the impact of the program until several weeks in. And that is really common in all of the ACT work that I do in clinic, as well as in these different studies, whether it's in cancer or in dementia caregivers, is that it's a new way of being with our experience. And sometimes it takes us a minute to get on board with that and to really embrace this new way of being with our experiences. I've had a lifetime of dealing with that, because I've been dealing with type 1 diabetes for 50 years. And so I learned from an early age kind of how to be okay, with the unwanted. But it takes a lot of people a little bit of time to do that. And so what we've done with that one is in our intervention for our randomized pilots, Taylor and the other interventionists are now adding a line in session 1 where they say, you may notice some feelings of skepticism about some of this, or it may be just a little bit confusing, but here's a quote from one of our participants in our pilot study. And then she reads, a really nice quote where the caregiver had suggested, just, hang in there. Just, notice those feelings of skepticism and hang in there and keep doing it, because it's going to make sense, after about 4 sessions. So that's a change that we've made to the protocol. the intervention manual. And then also greater clarity on concepts and the purpose of the exercises. So we've added just a little bit more guidance, where we kind of break it down for caregivers who are kind of trying to see, how does this apply, to my life? Also, several people wanted more sessions or more follow-up after the sessions. And so what we've done in our current pilot that's just now getting started, we've added a booster session 1 month after the end of the 6-week intervention, just to check in on their values-based action goals and to see, kind of how they're using the skills in their life, and then helping them to reduce barriers to using it. And then several people preferred face-to-face interventions. That is not something that we are thinking that we're going to implement, but it's nice to know what the caregivers say. So I wanted to mention to you kind of our current progress is, as soon as we got these stellar results from this Regenstrief funded pilot, we applied for a CTSI pilot so that we can conduct a randomized version of tactics. The problem, though, was that we started it right when COVID hit, and our results for the randomized pilot are a little different. They're not quite as we're not going to write home about those, as easily as we have these Regenstrief funded pilot data. And so we wanted to try again. We continue to learn more every time we do it, but we wanted to try again. And so we also have Nicole led the development of a research retirement, or I think it's research retirement foundation. I think I have that wrong on there. And so we also have that pilot that's funded for a second randomized pilot, and it's underway right now.
I would just add that Research Retirement Foundation, it's equivalent to an RO3. So it's a full year with sort of more funds than we've had previously. So we were able to do some additional things, like test some additional measures. But the biggest thing is that we actually have also started to engage some partners at Cleveland State University and the Benjamin Rose Institute in Cleveland, because the hope is that we'll be able to then do a multi-site RO1 application, which would be the goal. So that RO3 kind of expands it and brings in some new partners.
Yeah, and because it's really looking like, that was one of the things that I've noticed, because I'm used to like rapid recruitment in cancer. Like I said, for my pilot, we recruited 91 breast cancer survivors in 12 weeks. It's a little bit slower going for these dementia caregiver grants. And so it really looks like a multi-site trial would be really helpful. And part of the problem, which is a really nice problem to have, is that there are so many people here at IU, several, here at Regenstrief, who have funded studies testing interventions for dementia caregivers. And so the pool keeps getting a little smaller in that way, it's a great problem to have. But that's why I'm glad that we're partnering with the Cleveland State folks as well. So, well, anyway, thank you all so much. We appreciate the funding from Regenstrief Institute. I personally appreciate Nicole Fowler's vision, and I appreciate all of the members of our team and these dementia caregivers who donated their time, to join us for this study.
Great. Thank you so much, Shelley and Nicole. We have just a few minutes left for questions, and I am curious what is on your minds. There is one question in the chat that I can read from Jennifer West. Jennifer West, sorry. Thank you for such a great and interesting talk. In your larger study, do you anticipate any trends or correlations between caregivers and persons with dementia relationship and efficacy of the ACT intervention? And do you think a personalized ACT intervention plan catered to that dyad may be something to consider in later studies?
So can I ask, just to clarify, is the thought that maybe the relationship between the dyad could have an impact on what the efficacy or effectiveness, I guess, of ACT could be? So if it's a spouse caregiver versus an adult child?
Yes, that's what I was asking.
Mm-hmm. So I think so. I think our samples have been pretty small. So I will say that we haven't, other than looking descriptively about the breakdown type of relationship, We haven't statistically tested it, but there is a fair amount, I think, that we've hypothesized that the relationship would be different, partly because of what we were targeting anyway, right? So this existential suffering may feel different if it's your spouse who's been, your partner in life for 62 years versus maybe your mom who, now they're the reversal. So there is some sort of family systems idea regarding the role that I think that we would look at that would be part of a larger trial.
And I did want to mention it's separate from this study, but I was also part of an R21 that's led by Dr. Catherine Mosier in the Department of Psychology. And she tested a dyadic ACT intervention for the person with cancer and their family caregivers. And the results aren't finalized yet. She's still working on that. But it was interesting to enroll the dyads together. I don't know how this would work for people with dementia, though, because it's a pretty cognitively complex intervention. So I didn't know if Jen, if that was the question that you were asking, like, are we thinking about a dyadic intervention?
Yeah, that I was just curious. I don't really know a whole lot about the ACT interventions that you guys are doing, so I didn't know if that was something that came about. It was just something that I'd been thinking about with our NP study that with Greg Sachs.
Mm-hmm. Yeah, it's definitely something to think about. I would think that the person with dementia would need to have pretty early stage dementia in order to be able to really engage in the ACT intervention. But I think anything that the caregivers can do that can help engage the person with dementia in actions that are consistent with the person with dementia's values. And if they know them really well, they might have a pretty good sense of that. And that might be something that could be meaningful for the person with dementia as well.
Great.
Great.
Thank you.
Sure.
Thanks for that question. There's also a question in the chat commenting on the number of female caregivers, and I'm wondering why there may not have been any male participants.
There were definitely some male participants. There just weren't quite as many. I can't remember exactly what the percentage was, but we were heavily female.
Yeah, you know what? Let me say, it is not unusual of people who agree to participate in studies and the demographics of caregivers that there would be more females. I think the response to your comment, which is interesting, is I don't know if we looked at refusal rate or ineligibility based on sex. So that would be interesting. Were females more likely to report clinically significant anxiety, which made them then eligible, or some other, so that would be interesting to look at. But I don't think that was something, we didn't intentionally oversample females caregivers.
Great, thanks. Grayson had praise for your presentation, and they asked, how were you able to maintain participation and retention in your pilot study? And I share Grayson's question. I thought it was interesting. You had participants who didn't see or understand fully the value of the intervention until later on, and until the fourth session. And it's interesting, you still had really strong retention.
Yeah, well, I think the piece to that maybe, and Shelley's already alluded to how amazing Taylor is. They found it enjoyable, but maybe didn't quite make a connection between their role as a caregiver. So I think that's the value piece. Maybe it wasn't that they didn't enjoy it, but I will say that, and Shelley alluded to, and then the randomized pilot that we did during COVID, we did have a higher withdrawal rate. And we don't have any qualitative data to understand exactly why, other than COVID. We have a little bit of sort of demographics to help us understand that. But so it is interesting. I think that the retention was exceptionally good, especially since it was 6 weeks. The exact same 6 weeks, we had a larger withdrawal rate in the randomized pilot. And we're chalking it up to kind of COVID, but we don't know. And we had the same, part of most of the intervention was done by Taylor in that arm too. So.
But I also think just the demographics were slightly different between the two studies. And I think this was more of a well-off, highly educated sample. And I think we had a little bit more of a broad sample in the second pilot. So, and I also think that just the components of the intervention session, I mean, they're interesting. Even if you're like, I don't see how this applies, they're still interesting and engaging. I mean, there's lots of fun activities and, you know, kind of insight generating activities. And I think it kind of gets people, you know, really curious about, wow, what's going to be in that next session? I think it is kind of a page turner for people a little bit. And we had some qualitative quotes that kind of alluded to that as well.
Great.
And Bronson, your question about the demographic makeup, I will say that we were not doing a very good job of paying attention to that at the time of recruitment. And we sort of saw it when we were done, and we're like, oh, that certainly was not the goal. I feel like maybe the strategy and like the sample that we recruited from for the pilot initially, like the single arm, was sort of more of a, I don't want to say a convenient sample based on maybe participants who had already screened out of another study. So we knew they were interested in research because somebody had already approached them, but they weren't eligible for that caregiver study. So they were already on a list. And so I think there was a little bit of a trickle down. We did a little bit more public facing as well, like the support groups. And so I don't know I don't think there was a refusal rate differential based on race, but I will say that we're trying really, really hard in our current pilot to ensure as much diversity as we can, both in race, sex of the caregiver, and then also relationship to the caregiver as well.
Great. All right, we are at time. Thank you so much, Nicole and Shelley. Great job, and we appreciate your sharing the great outcomes from your Regenstrief funded pilot. Thanks, everyone. Have a great day.